All right, so for the last of the early morning lectures before Q&A, we will have Leone Barron. She's a physical therapist at the Sports Medicine Center for Young Athletes here in Oakland, and she cares for patients with sports injuries and other concerns related to athletic performance. She's special interests in strength and conditioning, as well as helping young athletes return to their sports. After earning her bachelor's degree in exercise biology at the University of California, Davis, she earned her Doctor of Physical Therapy degree from Samuel Merritt University. There's a lot of us from Samuel Merritt University. She completed a residency in sports physical therapy as well with us 4 or 5 years ago. Here's Leone.
Thanks, Tom. Hi, everyone. So I'll be talking on weight training in young athletes. Before I got started, I just kind of wanted to touch on my connection to the topic. I grew up a competitive soccer player, was one of those that definitely specialized really young. And I found myself having these overuse injuries and needing surgery in my early teens. And in high school, I found the sport of weightlifting. And I got to see firsthand the effects on my performance as an athlete, and also the decrease in my injuries that I was getting as I moved on to higher levels. All right, so nothing to disclose. These are the objectives. I'm not going to read them off, but just a brief overview. I'm going to talk about some important definitions, the reasons that we would want to strength train in this population, some misconceptions and special considerations, current research, programming, dosage, and if we have time, we'll touch on a case example. Okay, so these aren't all the terms I'm going to be using in this topic, but these are some important things to define moving forward. So in research and also for the rest of my talk, when the term weightlifting is used, it's specifically talking about the sport of weightlifting. So that's the sport that we've seen in the Olympics, where you perform 2 maximal lifts, the clean and jerk and the snatch. I'm not going to really be talking a lot about this in the talk, but I do want to touch on it a little bit. And then resistance training is really what I'm going to be talking about for the majority of my talk today. And that's just training when an individual is placed under a resistive load. And that can be with a variety of different things like weights, bands, machines, etc. And it's used to improve fitness, health, and general performance. And then another key term is physical literacy. This is really important in this population, working with kids. This is really what we're trying to instill, regardless of if a kid is less active or they're a higher level athlete. And that's the ability, confidence, and desire to be physically active for life in a variety of activities, environments that benefit holistic and healthy development. Okay, so why would we strength train in this population? I'm going to highlight some key points and benefits specifically in the pediatric population. So moving on. This is a diagram from a book on youth fitness. It's a little small, but I can kind of touch on the points of it. Overall resistance training has been shown to increase physical literacy and decrease injury risk in this population. Stronger youth are more efficient in their movements and are more competent in their abilities. So that's what increases that physical literacy that we're looking for. And they're more prepared to participate in moderate to vigorous physical activity that's required for sport. And it's been shown that resistance training in youth as young as 6 all the way up to 18 have those improvements in aspects that are needed for sports performance. So to name a couple, running speed, kicking velocity, balance, etc. And all those things lead to decreased injury risk. So in this diagram, it's a couple things that are important to highlight are the bone mineral density changes that can occur when we use resistance training in this population. So decreasing fracture risk, improving bone density, improvements in cardiovascular health and motor skill development, among some others as well. Okay, so this is a concept that I think a lot of us are familiar with, a public health concept that has been discussed in recent years, that there's this dichotomy in activity levels in youth that's happening. So Kids that don't participate in sport are becoming less and less active as time is taken away from physical education in schools and funneled to more educational academic topics. And then those kids that do participate in sports are specializing earlier and earlier. And each side of this dichotomy comes with its own risks of injury and negative health outcomes. So just to touch on those, in the inactive or less active population, the World Health Organization cited that inactivity is the fourth leading non-communicable risk factor for mortality. And less active kids tend to have lower fitness levels, which increases their risk of activity when they do participate in something physical like a sport. And then in that early specialized population, they're really focusing on a specific set of movements. They have less diversity in movement and less time for free play. And resistance training can provide that diversification of movement and address strength deficits that are present. And it has also been shown that athletes who diversify movements and strengthen from an early age regularly have an increased rate of long-term success. So it doesn't take away from their success, which is an important educational piece when we're working with these athletes. And then in both populations, we see that decreased strength training earlier in life leads to an increased risk of negative health outcomes, and resistance training during growing years can improve long-term health, fitness, and sports performance. Okay, so just want to touch on some misconceptions that have been addressed a lot in research in recent years, and then some special considerations in this population. So some previously held beliefs that often dissuaded people from recommending resistance training in this population was the concern for an increased risk of growth plate injury and decreased long-term growth. And then the concept that there might be decreased gains due to decreased levels of circulating testosterone pre-puberty. So talking about the growth plate injuries, it's been reported in many studies that with safe mechanics and proper supervision, there were no fractures reported during resistance training. So under the correct supervision and training, these kids didn't report any fractures. And it's also been cited that equal or greater forces can be placed through the long bones during specialized sports or even playground play. And then for the most recent International Olympic Committee consensus statement, research shows that resistance training will not have any adverse effects on linear growth. Moving on to concerns and gains in children. Children, even pre-puberty, have shown increase in strength and power when they participate in resistance training when they're compared to their age-matched peers. So depending on the age, these changes may be due to more neuromuscular adaptation versus hypertrophy, but they're still showing those improvements and benefits. There's also a large window of adaptation, meaning there's a lot of room to grow in this population, and there can be a significant benefit in really learning proper mechanics, weight room etiquette, training habits to take that forward for a lifetime of healthy habits. So some special considerations in this population. As I touched on before, childhood is a really important time to intervene with strength training to assist in building bone mass and enhancing bone structure. Proper form and athlete competency as well as provider competency is very important to be safe and reduce the risk of injury in this population. And I just wanted to take a second on this slide to talk about young female athletes, because that's another passion of mine. Young female athletes who didn't participate in resistance training were more likely to develop faulty mechanics and therefore increase their risk of injuries when compared to their peers who did participate in resistance training. There was also an interesting clinical review done in 2018 that compared strength and conditioning programming for young female athletes compared to their male counterparts. And it was cited that those strength and conditioning programs for female athletes were more likely to be provided by people who were not properly certified. This feels like something that we can really, all the people in this room can really address and make sure that we're giving our young female athletes their due and making sure that they're getting just as good a programming as their male counterparts. Okay, so the next couple slides, I'll briefly touch on weightlifting in youth, and then I'll kind of go back to resistance training. So there was also a IOC consensus statement on weightlifting, the sport of weightlifting in youth athletes. It can improve performance in many variables like resistance training, specifically those more powerful movements, so like sprint speed and jump production. It's been shown that it actually has lower injury rate than some other specialized sports, again, if it's properly programmed and under proper supervision. And when to start. So children should be able to follow complicated directions. If anyone's watched, I don't know, has anyone here watched Olympic weightlifting, like in the Olympics? Yes. It's very complex. It's very fast. So they should be able to follow complicated directions. They should be able to focus on safety. And some recommend that this can be done as young as 10 or 11 years old. I just wanted to touch, and I'll talk about this later too. It can be started as young as 10 or 11. We are not loading these kids the same way we would load a 16, 17, 18-year-old. You're starting with weight room etiquette, motor skill development, just like we would when we're learning any new skill. So teaching good technique, weight room etiquette, and safety is key for this population. And this photo is CJ Cummings. This is a while ago, but he was 16 in this picture, and he set the record with this lift. Okay, so current research, and I'll start by talking about current research with weightlifting. So there was a study that compared the sport of weightlifting and training to traditional strength training. And it was shown to have similar increases in muscular strength, squat jump performance compared to traditional resistance training, but was better at increasing sprint speed. So my clinical pearl from this is that it's a good inclusion in a program, but it should not ever replace traditional resistance training. It's good to also work on some other things with traditional resistance training and use weightlifting as more of a power production training source. Also, when properly supervised and programmed, there were multiple studies where no injuries occurred that caused lost training days in preteens and teenagers that were competing in weightlifting. So again, I think the key of this one is that proper supervision and programming for the athletes. And in athletes as young as 12 up to 22, weightlifting produced positive changes in body composition, cardiorespiratory variables, fitness measures, and weightlifting performance. And then just some research on resistance training in specific populations. So I mentioned this stat earlier in a previous slide, but as young as 6 years old, we see those improvements in variables for sport that decrease injury risk. And when injuries did occur during resistance training, they occurred as a result of fatigue. So again, improper programming and poor supervision. And then going back to that dichotomy in youth activity levels, those early specialized athletes can benefit from those strength deficits, from addressing the strength deficits that may contribute to the risk of injury. And even though these are active kids, they still need improvements in physical literacy because they don't have that diversity of movement. So using resistance training as a way to bolster that is good. And then those who are less active benefit from the introduction of motor skills and strengthening. But something to note is that they may not be ready for the same level of loads as some of their more athletic counterparts. And an interesting point that was shown in research is that these less active individuals might actually have an advantage when it comes to strength training because it was shown that there was an increase in initial gains in the young untrained individual compared to their more athletic counterparts. And then coming back to female athletes, similarly showed actually a larger training-induced improvement in sports performance than their male counterparts when they participated in resistance training. And also children showed that same higher training-induced gain compared to adolescents. That is likely due to neuroplasticity, but it's recommended that children have adequate maturity, balance, and postural control before you start resistance training, and this usually occurs around 6 or 7 years old. Okay, so talking about current research with program building, dosage, as I'm sure people aren't surprised, there's some conflicting evidence and recommendations with dosage, so I tried to make it as concise as possible. There's a couple studies that recommend performing 2 to 3 sets of 8 to 15 reps with loads between 60 to 80% 1 rep max for 6 to 8 exercises. It's also shown that there are greater improvements in those sports variables, running, jumping, throwing, when there's a greater exercise intensity. But it's really important to consider an athlete's training age, meaning how much time they've had with resistance training, how familiar they are with it when you're starting to really load a younger child. There's also data that higher rest periods of 3 to 4 minutes correlate with higher strength gains. I hypothesize this is probably due to higher rest allowing athletes to complete that higher intensity that's been shown to have greater improvements. And then there's a recommended frequency of at least twice a week with rest days in between. This chart I thought was really interesting, and it was in one of the clinical reviews for resistance training in athletes. And it uses biological age, so peak height velocity, pre-peak height velocity, post-peak height velocity versus chronological age, and kind of showing how we should be loading kids at these stages of puberty. So in that pre-peak height velocity, so in this chart, that correlates with the younger kids, 10 or 11. We should be really focusing on that foundation of movement, developing motor skills, creating general strength, and therefore doing lower weight, higher reps as we get them more familiar with technique. And then as they get a little bit older into their mid-teen years, thinking more about higher intensity strength development, lower reps, higher weight, and starting to introduce a little bit more load into the more powerful type movements as appropriate for the individual. And then when we get later into later teen years, really we can load that athlete as tolerated, higher intensity loads, starting to play around more with 1 rep maxes, that type of thing, as they're entering adulthood. Okay, so this is a big noisy chart about when to load an athlete. This was originally used in terms of just sports load, but I think it can carry over to thinking about adding in additional resistive load as well. And it kind of takes a green light, red light, yellow light approach to adding in resistance training for an athlete. So starting with that low risk, load tolerant athlete, we're looking at sports specialization, if they have an injury, competition hours per week, that type of thing. And this kind of low specialized athlete who's not overtraining is a great place to intervene and start building that strength preventatively. So you're good to go ahead and start loading that athlete. This kind of middle load naive athlete has a moderate degree of sports specialization, but they're still not overtraining. They might have some aches and pains, some low risk overuse injuries, but nothing too detrimental to their performance. These are kind of a proceed with caution. So you might recommend decreasing their sports load a little bit as you add in more resistance training, so you don't push them into that overtraining athlete. And then finally, this high risk load sensitive athlete. This is, the athlete that's been specialized in one sport for many years from a young age. They are having a lot of overuse injuries and pain. They're doing more workload per hours per week than their age, kind of like the classic athlete that some of us have had come into our physical therapy clinics that are really into their sport, which is great, but they're having a lot of injuries. And these are ones you want to stop or significantly decrease their load and adapt. So The recommendation here is to call your sports medicine provider, recommend decreasing workload, address their injuries and their deficits, and then slowly ramp back up. So we see this a lot in the sports med clinic. And I also wanted to briefly touch on programming and periodization. So the NATA position statement recommends emphasizing strengthening 2 months prior to the onset of the sports season to slowly ramp up intensity leading up to the season so athletes are ready. You can consider periodization cycles with this, focusing on strengthening in the off season. I will say with the growing specialization in sport, this can be really challenging as a provider to recommend a true periodization cycle because a lot of kids don't have more than a month or two off in any given year. And then one thing to note is strength training should never add to overtraining of an athlete, but it should be something that is maybe taking away a little bit of time from sport-specific training. This is an example for your guys' records. I know you all have access to these slides of like what a periodization cycle might look like when we're taking the competition and pre-competition into account, and what types of programming you might do at each area of that of cycle. So you'll see that the strength training and endurance training is before the season, and then during the season you ease off of that resistance training a little bit. Okay. So before we go over the case example, I wanted to just kind of summarize some key points. I think the main thing I wanted to try to get across in this presentation is that resistance training is very safe and important to perform in this population. It needs to be done by people that are trained, and it needs to be done with that individual in mind when it comes to loading. And then, yeah, so that's pretty much it. So case example, a 16-year-old female soccer player plays club soccer and is on the high school varsity team, presents the clinic with bilateral anterior knee pain, 6 out of 10 at worst, usually tries to just play through the pain because playoffs are coming up and she's a full-time starter. So what are your recommendations for this athlete based on that load sensitivity chart that we went over, which I'll kind of go back to it. And there's no one right answer if people want to just throw something out there.
To the moderate category.
Yeah, I think this athlete, depending on like your exam and other things that come out in terms of how much they're participating in sport, could fall into that moderate or even high risk category if you did some other exam and learned something new. Anyone else? Nope. Okay, so, and again, this is meant to be kind of a discussion, so I think there could be multiple answers for this question. What strengthening intensity and dosage would you consider using for this patient? Tom?
I think for me, looking at that, I would probably be in a very minimal category based on where she is in season. And where I would probably have at that point.
Yeah, I think that's good. I think obviously there's a lot more assessment that needs to be done. I left this very broad on purpose. But if they're having that much pain, they're already overtraining, you'd want to introduce load very cautiously and addressing their areas that they might have deficits. And then that moving on from that, once this patient is pain-free, maybe they're in their off season, what recommendations would you have as a maintenance program for this patient?
Will increase variety with your training.
Mm-hmm.
If doing non-soccer stuff.
Mm-hmm. Yeah. So, but I think the key recommendation is like continuing to maintain strength training and tying that into their already probably very busy training schedule, but trying to educate on the importance of long-term benefits if this player's obviously a very competitive athlete and hopes to play for many more years. All right. Thank you.
Oh, don't wander too far. Thank you very much. for the talk. I'd like to invite Heather, Dr. Chow, and Leone back up to the table for a Q&A session. Caitlin had a secondary engagement, so she will not be joining us. With that in mind, if you do have any questions about the return to impact for gymnasts, please come talk to me and I can give you her email. She'll be more than happy to answer any questions you might have. All right, so we'll open it up. Does anybody have any questions in regards to the hip hypermobility or weight training?
One of my first questions was with regards to your talk on hip injuries and hip dysplasia. And one of the recommendations was for that activity modification, and for maybe like an impingement, that makes a little bit more sense to me on how you would modify the activity. But for someone with hip dysplasia, what would you suggest in terms of activity modification or changing their program?
Yeah, so. Hello.
Yeah, it should be good.
Should be good. Can you hear me? Good question. So first, it's their main activities that they come in with. So you can modify those, whether it's gymnastics, whether it's dance. You should take a break from those. Typically, I say like the duration of which you have had your symptoms, double that for your break or for your shutdown period. And then do physical therapy to strengthen all the muscles around the hip. Try to stabilize it, because for hip dysplasia, it's a lot of maybe micro instability. And then if there's any labral component, whether it's a tear, whether it's hypertrophy, it's inflammation. So hopefully that shutdown period kind of relieves that inflammation as well.
Good morning. My question's for you, Heather, and it's regarding, we know that therapeutic exercise and neuromuscular re-education is, of course, key with hypermobility. But in terms of taping, of course, the evidence was kind of meh on that chart that you showed. But clinically speaking, with experience, are you still taping your hypermobile athletes? And what place does that have with their rehab?
I do not tape them a lot. When we have not found other modes of treatment that can be helpful, then I will try it just to, sometimes the patient just feels better. Whether or not it's a true benefit or not, it's always tricky to determine. But I will use a lot for postural retraining, more so in stabilization. But again, it's just gonna always come back to that particular patient, what's working for them, what's not, maybe starting back at a lower level, building up that strength, as much as you can. So there's not like a perfect answer for that. It's kind of a little bit of trial by error of what works for them.
Any other questions? Oh, awesome.
This is just the way that they do weightlifting and CrossFit. Obviously, your opinions on that, because I obviously not for the younger kids, but some of the older teens and young adults, and they have these ridiculously high jerk things, and I'm like, no, that's the trend.
I think the thing with CrossFit is there's a huge range in any gym that you go to. I think similarly to Olympic weightlifting, in the general population, if it's done with proper programming and proper loading, it's less dangerous. And there's also been, I didn't talk about this in my study, there's also been studies about injury rates with CrossFit versus like long distance running and things like that. And it's actually been cited lower than some other more higher intensity sports. But all that is to say it really depends on the programming and where they're going. I personally wouldn't recommend it for any of my younger teen athletes. Similarly to you wouldn't recommend higher intensity Olympic weightlifting unless they're on the Olympic track for that. So if you're using it as a training mode, in that chart that I showed, it really showed it starting to progress the intensity of that in more like 18, 19, 20-year-olds. But that's just my personal treatment style. Yeah, I didn't necessarily do a ton of research on that for this talk.
A lot of times, I'm a primary care pediatrician, so parents come in and want to know about weight training, and if we say to them, as long as there's proper programming and supervision, then I know the follow-up question is going to be, how do I know my kid is getting proper programming and supervision? So are there like red flags parents should look for, like resources they should go to, like how do they make sure that their kid is participating in a proper program?
I think one thing that's helpful is looking at certifications. So making sure the people providing care is properly certified. There's also special certifications for youth strength and conditioning. That can be an added plus. And I think also just even like touring a gym and seeing what the environment is, making sure there's individualized care. Like for example, using my personal experience, when I started weightlifting, I had an individual program that I did, and my coach was there with maybe 3 other athletes. So I think really making sure there's that proper supervision, and it's not one coach with 10 kids doing strengthening is a good environment to make sure they're in.
Any more? Oh, there we go. Getting my steps in today.
So building on that last question, the population I work with, I'm happy to have them moving or exercising at all. They're not in any way going to be specializing in any unique sport. And so I would assume they're not in a highly supervised environment. So when I've got a 16, 17-year-old guy who's probably managing his own weight program, and I'm often making sure, is somebody spotting you in some of those weightlifting positions? And the guide I've given them is they should never be lifting over their own body weight. And I realize you're speaking from a sports medicine perspective, but from a more general perspective, for these growing kids that are possibly and very likely making some of their own decisions, can you give a more narrow guideline? Am I heading the right direction of more repetition, less weight is better?
That was top.
In short, yes. Yeah. I feel like if it's people that you're just trying to get moving and getting them interested in doing something physically active, they do not need to be maxing out on anything. Especially if you're unsure of their supervision, I think that's a very safe recommendation. I think the big thing is just to not assume, which it sounds like you're not, but to not assume that kids that don't necessarily want to participate in a sport might not enjoy resistance training. I find that sometimes that's kind of the avenue that people find, that they're like, oh, actually I am into this and I could maintain this for a lifetime. So making sure to still encourage that, but with safe recommendations like you're doing.
I guess, all right. It's about to be my turn.
One more question for Leone. Upon your experience and knowledge and your research, how did speed, agility, and plyometric training kind of impacts the recommendations you set forth?
So I focused my research on this topic into specifically resistance training and the sport of weightlifting. So I didn't go down the conditioning realm and strength and conditioning, but maybe that would be a good idea for a talk next year.
Absolutely. All right, so for Dr. Chow, when you have the 10, 11-year-old skiffy patient that comes in and we give them the you can't weight bear and you need to minimize your impact, how do you balance that with being active, and how do you balance that with sanity for the parents when the kids are, having to really dial back from their activity levels?
Is this when they first get diagnosed or after they get treated?
Either or.
Okay.
Yeah.
So when they first get diagnosed with SCFE, it's almost all the time surgically indicated. So we want to get them to the OR as soon as possible. If they come into the clinic, we usually tell them to go to the ED and get admitted. They can stay overnight and they get surgery the next day. I think that post-operatively, that may be where your question is more applicable, because if it's a stable SCFE, at least in my practice, they're not going to return to sports or activities until 3 months and 6 months for unstable. And then, like I said, ideally that they would fuse before going back to contact sports. So that could take a while. It could take like up to a year and a half. So in terms of counseling, it's hard. I think this is where maybe like sports psychology can come in. They can try less impactful sports, swimming, cycling, things like that. But it's a discussion you have to have with the patient and family. Most of these kids, based on the risk factors of which demographic gets SCFEs, they're, sometimes they are football players, but most of the time they're not actually. But your question does apply sometimes, and those are the cases that are difficult. But you just have to protect them as best as you can. So.
Awesome. And then one more for Heather, and I'll leave Leon alone since she got up. Excellent. All right. Well, for Heather, for hypermobile athletes, I tend to find in my practice that those are also the ones that are drawn to sports that need excessive mobility. How do you balance protecting them while allowing them to do the sport they may be excelling at or may want to do more than others?
A lot of patient education to start, and teaching them joint protection, reviewing certain extreme positions that they're getting into, and trying to problem solve on ways to protect. Using those stabilizers and making sure the stabilizers are strong enough, and then also working through any tight structures. So are they tight in one area, compensating somewhere else, and that might be causing the issue, or causing more extreme joint positions. So basically looking at the entire person and rebalancing where they're tight, where they're weak, and then really, I always want my patients to leave with the knowledge that they know how to take care of their body. Like, I feel like I've done my job if they can leave knowing, okay, this is what I need to focus on, what I can do better, and I think that's the best way to manage them.
You don't just tell them to charge so they can be in surgical. You don't just say you're going to be in surgical so they can grow
I mean, if that's a goal, then we could,
I'm saying that, but our one there is that challenge. Clearly, I have no ability.
Yes, absolutely. But they're also very strong, and so I'm sure they have pain. I don't doubt that some of those athletes have pain, but they tend to be very strong, so they do know how to manage it better.
Thank you all. I appreciate all of your talks this morning. They were really helpful. My question's for Heather, and it's regarding the nutrition for the hypermobile athlete. It's often a question, we address the physical aspects of it in physical therapy, but I find that I'm hearing that question more and more about nutritionally what they can do, and I notice that it's on multiple slides that you have. The anti-inflammatory diet aspect makes sense for someone who's irritable, but I'm just curious if you have other nutritional recommendations.
So oftentimes, especially with like our gymnasts and our dancers, we will see nutrition issues, right? Or maybe potentially eating disorders because they're trying to have a certain look. We do refer to our sports nutritionists when necessary. As far as like a certain diet to follow, I don't have any. I haven't done research on that, so I don't feel like I could give you good information. But just having that conversation with them, just gently as you get to know them and build trust, talking to them about what are your habits. How much water do you drink? Just kind of get a feel of how they're eating, and then either refer them or if it's something that I feel like I can address, very simply, then talking about that too.
Did that answer your
Yeah,
question?
that answers the sports nutrition referral option is always.
Right.
I consider that.
Yes, and we could get you a contact for somebody if you need somebody. We do have somebody within the UCSF system. So.
All right.
You may have already addressed this sort of with looking at certifications, but I find I'm having all these teenagers now who are coming in who are finding videos on YouTube and doing all these programs at home on their own through YouTube, and I don't know how to direct them to a good program, or I don't know, does UCSF have something online that I can direct them to, or are there good programs out there that I can say, hey, you want to go to this site or this YouTube channel? There's so much online content now, and I just don't know what's safe and what's not.
Heather just brought up a good point too. I get the TikTok recommendations. Yeah, that's one that I get a lot. And they're always really bizarre. But I would say, I know it's hard because there is a cost barrier with seeing someone that's certified. But I would encourage athletes to look into, like, some schools have a strength and conditioning specialist. Some of our public high schools, I know, have strength and conditioning specialists on staff. I generally try to push athletes away from just looking stuff up online, especially in the pediatric teenage population, because a lot of those recommendations online are for adults, not for teenagers. So I generally try to have them work with someone that has some strength and conditioning specialization, NCSM or something of that sort. And if they are interested in competing in Olympic weightlifting too, there are gyms in this area that do that, not CrossFit. You want to make sure those providers are USAW certified, so USA Weightlifting certified. So those are kind of things I look for. It's unfortunate because, like I said, there's like a barrier because not everyone can afford to work with a trainer, but that is the best consensus recommendation is to be working with a skilled, certified supervision. So.
I've been getting a lot more kids, especially boys, interested in just going to the gym with a bunch of friends, and they are having a lot of questions about supplements. Some of the gyms are selling them. So I'm just wondering what guidance you give them on that. And these are kids who don't have a lot of money.
To echo what Heather was saying, I've referred kids that are into more bodybuilding physique stuff at the gym to our UCSF sports nutritionist, and I'm pretty sure that's covered by insurance. I don't know, but there are nutritionists that insurance will cover if finances are an issue. But yeah, in terms of supplementation, especially in this population, I would recommend, again, working with a specialist. It's definitely not my expertise.
All right, so we're going to wrap up the morning session right there. We have a break and we'll restart at 10:35. Please make sure you thank our speakers and come up to them if you have anything else. And please go visit our exhibitors.